So you guys were listening to me but not seeing anything. Is that correct? Okay, well, there's the golf picture. All right, so back to this. So, you know, ENT folks were the folks that owned the esophagus. This Chevalier Jackson, the father of bronchoesophagology in North America, but it was as common. These are some of our European forefathers, but in-office procedures, even like T&E and even bronchoscopy, were commonly done with enough topical anesthesia years ago. If one looks at the history of esophagoscopy, this is predominantly, it's all otolaryngologists until the 1950s, or the late 1950s. And Basil Hershowitz, a gastroenterologist, published the first series of individuals looked at with flexible esophagoscopy. And he had a series of individuals with reflux esophagitis. And at that point, our specialty did not move forward in the area of flexible instrumentation, but maintained the use of rigid esophagoscopy and pretty much ignored the flexible modality. And we kind of gave up a lot of the esophagus to the gastroenterologist for many years. In mid-90s, Reza Shakir at the Medical College of Wisconsin developed the first ultra-thin technology in which a distal chip device was utilized on a thin flexible scope. It was actually transnasal EGD with a 110 or 120 centimeter flexible scope, but it wasn't embraced at all by the gastroenterologist. They're used to having people heavily sedated. They don't know nasal anatomy, and it was not embraced at all, but it was by otolaryngologists. Ingo Hermann, and in the late 90s, I think at the time he was in Italy, published the very first T&E paper by an otolaryngologist, and Jonathan Aviv in New York City at Columbia at the time in 2001 published the first North American study demonstrating the safety of transnasal esophagoscopy, and then it became increasingly popularized. Here's a picture of Dr. Hershowitz. A lot of cool instruments. This is a really nice instrument, half rigid, half flexible. Be a lot of fun to play with that, with a hand air insufflator. I get a kick out of this. This is a rigid scope. You know, an otolaryngologist, I love the fact that the patient still has his tie on despite undergoing this procedure. That's formality. So the key to this was improving technology, the large therapeutic scope by our gastroenterologists, down to the point where we have now endoscopes 5.1 down to 4.8 millimeters outer diameter, which are fairly easy to pass transnasally, since we do so with our 4.2 laryngoscopes right now. You've seen this already from the dysphagia evaluation. Why to do this is because there's a lot of pathology in the esophagus, and these are patients that otherwise are going to get missed by us. We've talked about this before. 75% of adults that don't have a neurological problem have an esophageal cause or contributing cause to their dysphagia. And once again, reflux, terribly common. We talked about referred sensation already, rule of 1/3. Maybe we should just call it the rule of 40% now, of people with distal esophageal pathology point above the clavicle. They term the GI people like to call that visceral hypersensitivity. So why do this in the office? First of all, every study, so far 18 of them, and I haven't looked probably in the last 9 months, demonstrate that there is no difference in the diagnostic accuracy between T&E and conventional sedated endoscopy, esophagoscopy. We'll talk about safety, markedly more safe. Patients prefer it. Every single series in which patients had both conventional and transnasal esophagoscopy, every single study, including those done by gastroenterologists alone, patients preferred T&E if they needed a third procedure, and it's markedly less expensive. Dwight always always the cynic, why not do this in the office? The key thing is lack of knowledge, is that people, they are afraid about missing something. But I'll be very honest with you, the esophagus is nothing compared to the larynx. The larynx has got a lot more subtlety, a lot more difficulty. diagnosing subtleties in people with voice disorders. If you think you can conquer the larynx as an otolaryngologist or laryngologist, you'll knock the esophagus out of the park. There are patient concerns, however. A lot of people don't want to have any discomfort. If people have a neighbor that had an esophagoscopy and they said, oh, I don't remember a thing, and it was perfect, and no pain, no anything, the patient may come to your office kind of not excited about undergoing T&E. In my experience, that's pretty uncommon once they get to know you and hopefully trust you. Questions come about GI conflict, especially early on. Essentially, there's no conflict. It's not like we're fighting over the same amount of patients, the same size of a pie. The pie is a lot bigger than we ever thought of before. If 50% of ENT patients have esophageal pathology, then we have way more patients than the gastroenterologist can even handle. And plus, they don't like to see globus patients. They don't want to see people with chronic cough. Most of them don't want to see head and neck cancer patients with dysphagia. Those are our patients, and we can take better care of them than the gastroenterologists. Talked about safety. This is older literature. I should probably try to hunt something else down, but a huge survey done in 2007 demonstrate that 2/3 of all complications and 3/4 of all deaths were sedation related. We take that entire question out of the equation. We don't sedate them. They're not going to get a sedation related problem. Well, what about this? These are not my patients, thank you. This is from a book, but esophageal perforation. 2 big series have been done, one out of Stanford, and I think one meta-analysis, I think in the Midwest, I apologize for not remembering where, demonstrated that the vast majority of esophageal perforations, particularly in people undergoing radiation therapy, have had undergone chemo radiation therapy, are done with rigid instrumentation and not flexible. So there's no reason. There he goes, Jay Piccarello, SEER study in 2010. Majority, by far, rigid. And the head and neck cancer population had the highest percentage of perforations. But the Stanford thing showed not a single perforation in their single center study, and with a perforation of 2.6% with rigid instrumentation. I'd encourage you to learn this technology because it's so much safer than just doing a rigid. Cost comparisons, they're both direct costs and indirect. The direct cost is probably, it costs us well less than 1/3. Indirect costs, or once you've undergone T&E, you can back to work. I've had numerous doctors here at the Medical College of Georgia that will undergo T&E and go right back and see patients, right back to the office. I've had students from the university come by. You get this done, you go back to work. Plus, there's no sedation. You don't need a second individual to miss work to bring you to your exam. Then when you're awake, take you back home and keep an eye on you overnight. They don't need to be there because they're not getting sedated. So there you have it. Faster, safer. You don't have to be NPO, but it is recommended. Way less expensive, exact same accuracy. I put down almost under safer. There was a single patient that had a perforation. It was a T&E done by a gastroenterologist in Europe who did not notice that he was in a Zenker's diverticulum, and he must have pushed hard, and he is the only recorded perforation. Some people have asked very, very intuitively, just the esophagus, is that enough? Should we do an EGDs on people? And this has been looked at 3 different times, but best by Wilde, 2004, that if you have extra esophageal reflux complaints, no reason to do an EGD. Routine GERD does not require an EGD, but abdominal pain, nausea, early fullness or early satiety, or a history of gastroduodenal ulcers, then an EGD is indicated. But I'd also add a person with a history of hematemesis. A lot of times, if you do have someone that has varices or something like this, or something needs to be banded or coagulated, you can't do that with a T&E scope. Plus, your ability to suction blood with a small scope is much more limited compared to the therapeutic scopes. And so patients like that are better served by our gastroenterology colleagues. Surprises. So we did our first 700 of these consecutive. We looked at our numbers and tried to figure out, well, what were unexpected? Well, Barrett's. We were stupid. And we should have realized we were going to see a fair amount of Barrett's. And now you look at the literature, 7 to 9% of our patients, otolaryngology patients, have Barrett's esophagus, biopsy proven. Candidiasis, we had almost 50 patients that had candidiasis, and only one had a reason for it. And almost everyone got better with a single 2-week course of diflucan. And these were not people on steroids. They were not people immunocompromised. They were regular, healthy people. That was quite a surprise. Trouble in head and neck patients. Every series so far published has showed a dramatic amount of esophageal pathology in our people with head and neck cancer, particularly those folks that have undergone radiation and chemotherapy. Well, why is that? Well, think about radiation therapy and xerostomia. One of the key defense mechanisms against reflux is salivary bicarbonate. When you have a reflux event, say 50 cc's of reflux comes up in your esophagus, number one defense mechanism, once you violated the esophageal gastric junction, is tertiary peristalsis to force the bolus back in the stomach. But the esophageal lumen is still covered with acid and activated pepsin. So it's still burning, it's still eating protein, it's still chewing up the mucosa. Salivary bicarbonate, every swallow, helps to neutralize that. If you've had radiation, full course radiation therapy or chemotherapy, you've got no saliva, no salivary bicarbonate. You have a reflux event. Your esophagus clears the bolus, but the acid and the proteolytic enzymes continue to eat away at the esophagus. Work done maybe 2 decades ago demonstrated that 100% of individuals that had had radiation therapy in this study, 100% of them had reflux esophagitis. So you should be attuned to this. And these people need to be on some type of anti-reflux therapy. EOE, eosinophilic esophagitis, was a surprise. We weren't expecting to find it. When we first started doing this 16, 18 years ago, it was barely reported in adults, and we were surprised. And we'll talk a little more about that in a second. Tolerance in the elderly. Oh my gosh, we were really worried about really old people, 85, 90. They had absolutely no issues whatsoever with this. So, seen this already, a cough patient with Barrett's esophagus, HIV positive patients. You know that any patient, HIV positive with esophageal complaints or dysphagia needs to undergo endoscopy sooner rather than later because of the amount of viral infections they can have and a significant increased risk of, so we say, strange fungal infections in the esophagus. Panendoscopies, we'll talk about head and neck. This is so safe in the elderly and ill patients, much better than putting people under general anesthesia. None of us have good OR cleaning and turnover times, so why in the world do a panendoscopy in the OR if you don't have to? We can do our endoscopies in the office, and then we do our biopsies in the office in these people. It's safer. We have no concerns about the airway. We've already mentioned it's less expensive. We don't take people off their Coumadin or Plavix. We have yet to have a complication. I'm doing this for many, many years. And like I said, you can keep these head and neck cancer people out of your OR. That's invaluable and a big help to either to your head and neck practice or to your colleagues' head and neck practice. This is a patient with a obvious supraglottic tumor. A resident did this entire thing. Maybe I'll advance it just a little bit here. See the important stuff here. There we go. Pooling in the esophagus. Pooling anywhere has to be explained. I don't care if it's the piriforms, you got to explain it. The Vlecchi, you got to explain it. The esophagus, same way. You have to explain pooling. So here's a person with a supraglottic tumor, and his entire treatment gets altered because he's got a surprise at the gastroesophageal junction. So he's got a tumor wrapping this. You take multiple biopsies. These are 1.8 millimeter cups that go through the 2 millimeter channel. And key thing here is multiple things, but the blood trail. You should make certain you have positive biopsies, but look at the blood trail to make sure you biopsied where you wanted to. So there have been 3 main studies that have looked at people with treated head and neck cancer, some just surgery, some radiation, some chemoradiation, some all three, in which they've demonstrated, much as I said earlier, huge amounts of pathology in the esophagus following head and neck cancer treatment. 2 of these in Taiwan at different universities and 1 in California. The highest one had 87% pathology rate, esophageal pathology rate after treatment. We should look at these people. We shouldn't be giving these. We should, number 1, be ignoring them. Number 2, we shouldn't be sending these to gastroenterologists. But is it going to make a difference? What's the timing? We like to do them on the anniversary of their treatment. You know, congratulations, you lived a year. Let me stick a 60 centimeter scope down your nose. But we don't know if this is going to make a huge difference in outcomes as far as survival is concerned. We are finding new tumors. We do think it's improving quality of life for fungal infections, reflux esophagitis, and so forth, but we don't know the proper timing or anything right now. Giant golf tees. This is at the Greenbrier in West Virginia. So what do we look at? Once again, let's just go through a few things that are fun about the esophagus. Once again, if you can figure out the larynx or be taught and feel comfortable, you can do anything in the esophagus. Patient on the right has rip-roaring, grade D esophagitis. So when you do this, and remember the orientation, the bottom of the screen is anterior because you're facing a patient sitting upright in the exam chair. There are 3 impressions one sees on the esophagus. You see the arch of the aorta, left main stem bronchus, and then the gastroesophageal junction. These are actually, at least the first 2 are not always easy to appreciate when one is doing a rigid examination, but they're very obvious, very apparent when one is doing transnasal esophagoscopy. This may be the single most important slide if one is trying to figure out transnasal esophagoscopy. What do we have here? This is the normal esophagogastric junction. So what do you have here? You have the gastric rugae, the gastric folds, if you will, and these end at the esophagus. That makes sense. The esophagus comes down and attaches to the stomach, right? So the mucosa of the stomach should end, you see the arrow here, where the gastric rugae join the esophagus. What else do we see? The terminal linear vessels of the esophagus dive deep when you hit the stomach. So these end at the rugae, which should end at the squamocolumnar junction right here in the distal esophagus. You're allowed to have 2 centimeters between the diaphragmatic crura and the rugae of the stomach or squamocolumnar junction. You can easily see the diaphragm by having patients, not always easily, but you have them sniff. When you sniff, the crura come together and you know exactly where they are. So that is perfectly normal. Perfection. What do we got here? Well, looks kind of wide open down here. You see rugae stopping here, stopping there, stopping here. But look at this color change. You have the salmon pink gastric mucosa extending beyond the rugae of the stomach. So this is esophagus, and this stuff should not be here. This is clinical Barrett's esophagus. We know Barrett's esophagus is a pathologic diagnosis, so one has to biopsy. You also note the terminal linear vessels go down to the rugae through the salmon pink mucosa. So once again, this is all abnormal. So it's clinical Barrett's. And when you see islands, whenever you see islands of esophageal mucosa, always 100% abnormal. So this patient would require biopsies in this area, and he actually had a little bit of carcinoma in situ up there. Once again, gastric rugae, end of stomach. Look at the pink gastric mucosa, the intestinal metaplasia up into the esophagus with the terminal vessels going through it. Once again, needs to be biopsied. Now, people, what do you do with all these biopsies? We biopsy sometimes when it's obvious, but more often than not, when I have a patient with clinical Barrett's, I am more likely than not to refer that patient to a gastroenterologist. Some of my otolaryngology colleagues disagree, but there is a specified protocol that you should do 4 quadrant biopsies for every 2 centimeters of Barrett's esophagus. That's a lot of biopsying. And although patients are pretty tolerant with these exams, biopsy after biopsy after biopsy, the patient gets tired of it. We get tired of it, frankly, especially if you do the proper number of biopsies. And sampling error has been demonstrated in the literature to be a real problem in people with Barrett's. In other words, you can get a negative biopsy here, negative, Barrett's, in situ, adenocarcinoma, that type of thing. Because sampling error is so real, biopsies done with the large therapeutic scope, I think, are the actual proper standard of care, in my personal opinion. So I send people with clinical Barrett's to my gastroenterologist and GI colleagues. Hernias, you get 2 centimeters. Here's your diaphragm. There's your squamocolumnar junction. You get 2 centimeters here. Paraesophageal hernias, sliding with the paraesophageal component. You'll be seeing all of these. And I've been amazed how many people with big hernias will complain of solid food dysphagia, and they can undergo repair of this very often laparoscopically. Even large paraesophageals. And so it makes sense to scope these people. Up here, you see normal. You have a scope going through here. You see this little heaped up area around it with no opening. This is a nice, tight gastroesophageal junction. Look down here, gaping, wide open, sliding hiatal hernia with a paraesophageal component in a patient with solid food dysphagia. This individual underwent laparoscopic repair, an improvement, almost complete improvement of the solid food dysphagia. Forward view. So you look at this and you think, well, things look okay. Here's your diaphragm, but look at this. Look at all this gastric rugae that are on your side, the esophageal side of the diaphragmatic crura. Big sliding hiatal hernia. You retroflex, gaping, wide open. Once again, this isn't rocket science. This isn't disagreeing over some subtlety of stroboscopy. These things are much more apparent than any of the little things we worry about in the larynx. What else you see? Esophagitis, infectious, non-infectious. Number one by far is Canada. And I mentioned before in our first series of 700, almost 50 people had candidiasis of their esophagus and did not have a reason for it and didn't have anything. I don't think I mentioned this earlier. They had no white dots in their larynx or their throat, only in their esophagus. People have dysphagia, sometimes painful, but a lot of them have reflux or extraesophageal reflux complaints. 25% are asymptomatic. Certainly more highly seen in HIV patients, transplant patients, insulin-dependent diabetics, chronic steroid users, and so forth. Reasonably significant candidiasis, but nowhere near what it looked like with that AIDS patient we showed you earlier. Small ulcers, but you can get rip-roaring herpetic ulcers as well. And this is an HIV positive patient with odynophagia from a textbook. This was not my patient. Nasty. I've never seen a herpetic thing, but I keep looking. Non-infectious, far and far away, reflux is number one cause, but followed by pill-induced caustics, and then we'll talk about EOE in a moment. In North America, maybe 20% of people have reflux esophagitis. The classic symptoms, dysphagia, regurgitation, sometimes cough. It's not important to go over the LA classification, but we do grade these as we go forth. And people will say, oh gosh, I don't know if that's a grade 1 or a grade 2 or a grade 2 or a grade 3. It doesn't matter. How are you going to treat these people? With anti-reflux therapy. The more severe, the more likely they're going to get a repeat examination. And your comfort level will determine whether you continue to see this patient or you refer him elsewhere. If you see someone with routine esophagitis, you can provide them with dietary changes, proton pump inhibitor therapy, alginate therapy, so on and so forth. You don't need a gastroenterologist to do that. But if you were to have something along the lines of a grade 3 or grade 4 LA classification, much more likely to seek help from your gastroenterologist, your GI colleagues. And I would think that would be entirely reasonable. Once again, it depends on your experience and your comfort level. But if you don't look, who is going to look? These are our patients, these ones that come to us. Look at the left. You can get this idea of repetitive erosions and healing, leading to stricture formation and decreased motility. This kind of not very inflamed versus this. This patient gets dilated. This patient gets anti-reflux therapy prior to a dilation. Mucosal bridges. Once again, same thing. These are classic. Looks like diverticulosis almost. But some people, a lot of people, will have these little holes. And this is just due to the repetitive cycle of linear ulcerations that heal. And then months to years later, another one, and another one. You'll develop this mucosal bridges that give you this pseudo diverticular like look in the distal and even mid esophagus. I think my fellow and I both put balls in the water here on 17 just the other day. So once again, pulling the esophagus, you got to explain it. Strictures, webs, rings, cancers, tics, foreign body, or severe motility disorder. You can't blow it off, just like you can't blow it off in the piriforms. This is actually the wife of a former resident that had solid food dysphagia and burning. And so you look in there, what do you see? Impacted medication, pill-induced esophagitis with a stricture. Most common cause of this nowadays is Fosamax, far and away. Ampicillin, tetracyclines, and so forth, or potassium pills were the top before, but Fosamax now is become the #1 culprit. And once again, it doesn't hurt to look. You tell these people once they're healed, take pills, lots of water, be upright when you swallow, avoiding double swallows. I probably should have put an HRM of this, but when you swallow, it can take 7 to 15 seconds for that bolus to get into the stomach. If you swallow a second time, the peristaltic wave in the esophagus stops automatically. It's immediate. And so if people are chugging these or taking a second sip of water right away to chase a pill, it's actually hurting the transport of pills into the stomach. You should take your pill, or 2 or 3 or whatever, and then not swallow again for 13, 14 seconds, or those pills will stop wherever they are in the esophagus. So we do a lot of education to people not to double swallow. EOE, fasting disease, we don't know a whole lot about it. These are early patients at Wake Forest. And this small thing here is the first patient I ever found was someone who underwent a routine T&E for solid food dysphagia, and saw a single stricture on some rings, but some people look like they have rings that they gag a few times. This patient gagged a few times, and the muscle contractions like that can almost mirror this. But I noticed there was blood all over the place. It was a very easy T&E, and I backed out and I used the suction on a little area right here, and there was bleeding after I suctioned. And I had read something before about this in the peds population, so we did some biopsies, rip-roaring EOE. And once you know this exists, you'll be surprised how many people see it. Adults with foreign body impactions and people with recalcitrant reflux complaints are the largest groups. In fact, we have had 2 residents, one at Wake, one here at MCG, with biopsy proven eosinophilic esophagitis. This isn't a rare problem. If left untreated over time, lots and lots of strictures. It is the hope that by treating these people, you can avoid this final long-term outcome. We look about it, trachealized esophagus, if it's small, whitish plaques, if you see easy bleeding during T&E, in our lab, 15 EOs per high power field. You have to put that on the pathology request, or they're not going to look for it. And it's also important to realize that reflux itself can cause some degree of eosinophilic infiltrate into the esophageal mucosa. Therefore, one should only biopsy people for EOE if they're being treated on proton pump inhibitors. And so if we're concerned with EOE, we make certain, most of them already are on them, but we make certain they're taking a PPI prior to their T&E and biopsy. You already saw that from the first thing. This from the pediatrics literature, looking at findings. In their literature, I've not seen this repeated in adults, 20% of people have a normal esophagoscopy. Therefore, they do multiple biopsies at multiple levels in children. No one has come out and stated exactly what needs to be done in adults. We, in people we think may have it, if we see white spots or linear furrows or triangulation, we'll do 3 to 4 biopsies in those exact areas if possible. Once again, patients tolerate this really easily. Once you've gone to 7, 8 minutes, they're getting a little antsy. And so you do the biopsies quick, but sometimes if you're still uncertain, they can undergo this with sedation and they can undergo 20, 30, 40 biopsies and won't bother them a bit. So when do I biopsy? If there are characteristic changes, if the patient has a good history we've already reviewed, particularly if any allergic atopic history, these people deserve our biopsies. Webs and rings, once again, we mentioned the hypopharyngeal ones, really common. They occur distally as well, the Schatzki's ring being the most common. Important thing, the Schatzki's B ring, always associated with a hiatal hernia, readily responds to dilation. The A ring is actually the top of the muscles that form the intrinsic lower esophageal sphincter. And this can hypertrophy and is much more difficult to treat. Some people have done dilations are usually ineffective, but Botox in this area, and now the use of POEMs in this area has shown great promise. Another Schatzki's ring in a hiatal hernia. Once again, that's out of a textbook. A great video, nice barium swallow with tertiary contractions. Schatzki's and a severe A-ring. That is not my patient. That was from a textbook. Webs, once again, we're missing a lot of these, and I'd really encourage you folks, even if you have a normal barium swallow, you're going to be surprised. Look at them frame by frame. Dilate these people aggressively, empirically. And by aggressively, I mean in excess of 60 French. Don't stop at 60 French. Most of our people, I'd say our average non-radiated patient, we start with 80 or 90 French dilations on them. And we found this more effective than just 50 to 60 French dilations. Once again, these webs are often missed if one doesn't look for them carefully. Strictures, I put this here for a particular reason. A 100% obstruction, this should not occur. This should never occur nowadays. In fact, it's required here now. This would have to be presented at M&M. But we do everything we can. You can't allow a 100% stricture to take place. You know, as long as you've got some degree of lumen, rehabilitating swallowing the patient with a intact lumen can be done. Once you've allowed 100% stenosis of the plate, you have to do a rendezvous procedure. You've guaranteed multiple procedures to a patient, and in general, they don't get the kind of results you get if you can keep the lumen open. And so whether or not it's a dust, a Dopphoff, or a small bore NG tube, you can't ever let this happen. Post-radiation stricture. This is kind of funny, actually. This is a long time ago. This patient was sent down for solid food dysphagia, and we just do same day. You know, we don't bother being NPO. If you just pop in the clinic, we'll take a look at you. This patient, we thought it's a cancer. You got an obstruction and a pre-stenotic dilation. And we were sure this guy had a tumor. We did have a stricture and a diverticulate form. And I'm not a big fan of corn in general. I asked this guy, what are you eating? And he had, this is years ago, and he had corn like a day or two previously. And I almost got sick to my stomach. And so this is one of the first people we did an in-office dilation under topical anesthesia on. So we dropped a guide wire, missed the corn, dropped the guide wire, and fixed him up just by dilating him in the office. And his age, he was like in the 80s. He wasn't going to survive resection of this distal diverticulum. So we simply dilated him intermittently whenever he had need of it in the office. Zenkers, you know, you don't get a great view like this very often. You usually just fall into the pouch. If you're in a pouch, if you see food right as the patient swallows, you get in, you know, don't take a running start and try to get through it. You know, the only perforation with teeny, as I mentioned earlier, GI doc with a Zenkers. Gentle suctioning, then blowing of air, and just a nice clockwise rotation with your wrist can often get out of the tick and drop in the esophagus. But we did a thing at Wake years ago, never got it published, but I think it shows some wisdom. When we could not easily get into the esophagus in a patient, we retrospectively looked at that group of patients. 100% of them had cricopharyngeal pathology, 100%. Some of them had diverticula. Some had manometrically proven failure of cricopharyngeus relaxation. Some had hypopharyngeal strictures. But if we couldn't get in the esophagus easily, then stop. Get a contrast swallow. You know, step back, reevaluate. But 100% of those people we had difficulty with had pathology. Lovely par 3 in Tucson, Arizona. No, I did not par it. I put mine, I think, over the back into the snake area and never saw the ball again. Barrett's, intestinal metaplasia. Skip that. Remember I mentioned earlier the difference between clinical Barrett's and real Barrett's. Clinical Barrett's is the salmon pink mucosa beyond the gastroesophageal junction up into the esophagus. Barrett's is the biopsy proven intestinal metaplasia. So that's what you need to get on these people. This patient was a chronic cough patient, no heartburn, with an adenocarcinoma at the gastroesophageal junction. In the literature from the GI folk, 2 to 12% of people undergoing EGD have Barrett's esophagus. 6 to 7% of patients with extraesophageal reflux. I think there's been a series published with a 9%, so I need to change that. 50 times higher incidence of esophageal cancer. Also a huge incidence of stricture as well. Not because Barrett's causes a stricture, but Barrett's is caused by chronic acid irritation, which leads to stricture formation. Once again, #1 increase in incidence cancer in Western Europe and North America. This is a critical slide. I don't know if you can read the whole thing there, but it's fascinating. In the last 25 years, the entire picture of esophageal cancer has changed. Everything published before 25, 30 years ago was squamous cell, squamous cell. Occasionally, you get an adenocarcinoma. Nowadays, it's almost reversed. Almost every series is at least 50 to 60% adenocarcinoma. Some are 80% adenocarcinoma. And it's not because there's less squame, because adenocarcinoma has skyrocketed, and no one knows exactly why, although some of the theories are pretty fascinating. But the entire picture has changed. When you look at the literature, surgical and GI, over half of the patients with esophageal adenocarcinoma don't complain of heartburn or regurgitation. This led a very interesting retrospective study out of Portland, Oregon by Rivas et al., published several years ago. It's retrospective, admittedly so, but they went ahead and looked at 5 or 6 years of their patients with esophageal adenocarcinoma and determined, why do these individuals show up in our office? And when they went through it, the number one thing were extraesophageal reflux symptoms. Not classic reflux, not regurgitation, but it was the extraesophageal complaints that brought them to the GI offices. And in fact, their multivariate analysis demonstrated chronic cough was the #1 symptom. Now, these were just GI surgeons and GI doctors, no ENT surgeons. They recommend everyone with chronic cough needs to have visualization of the esophagus. Well, that's a little crazy, I think. And in a lot of our experiences, we don't see a high incidence prospectively looking at chronic cough patients. But I think they still deserve to be evaluated one way or another, particularly if someone's, my gosh, if you're almost 50 and you're going to get your first colonoscopy, I tell people, I'm not going to T&E. Yeah, you might as well just I'll put down and make sure the GI doc does both an EGD and a colonoscopy at the same time. If you're 30 something, early 40s, then I'll do a T&E on you and look around. When esophageal adenocarcinoma becomes overtly symptomatic, it's often incurable. The best centers, 12, 18%, 3-year survival, a lot of them less than single digits. So that's why GI centers spend so much time screening patients, depending on their Barrett's esophagus. If you have significant length of Barrett's esophagus, you're going to get looked at maybe every 5 years. You have the slightest bit of dysplasia, maybe be done in 2 years. You have moderate to high grade dysplasia, they'll bring you back in 6 months and do it again. And so to me, since transnasal esophagoscopy is vastly safer than sedated esophagoscopy, way cheaper, both with direct and indirect cost, I think our role as otolaryngologists should be to scope these people. No one's saying you have to do the biopsies, but you should. I think we're doing our patients a disservice by ignoring this huge group of patients. Who needs to get screened? We were accused of screening of scoping everyone, and probably did at Wake Forest. We scoped each other. We scoped anyone. The joke was our indications when we first started doing this in Winston-Salem was the 2 indications. Number 1, you had to be physically present in our office. Number 2, you had to have 1 patent nostril. And that was about it, probably, because we scoped a ton of people. And we still don't have a great answer for it. So for me, this is what I do. If you have moderate to severe extraesophageal reflux symptoms, I think it makes sense to do an inexpensive, safe transnasal esophagoscopy. The American Gastroenterological Association classic indication is 5 years of gastroesophageal reflux symptoms. I think it's critical that if you have someone on PPIs, if they've been on PPIs a while, or you think they might need chronic PPIs, you have to look. I've personally been involved in 3 legal cases of individuals on chronic PPIs who had esophageal adenocarcinoma, and no one ever looked. So if I've seen 3, there are a lot more out there. So someone has to look at some point if they're undergoing long-term PPI therapy. Chronic cough is a plus minus. Poor response to anti-reflux therapy. By that I mean they probably don't have reflux. Reflux is probably the single most overdiagnosed thing in otolaryngology. So we blame reflux for everything. So if someone doesn't respond to either someone else's or your anti-reflux therapy, look, because it may not be reflux, maybe EOE, maybe something else. That's the 1.8 millimeter cups. So summary, adenocarcinoma Barrett's, big problem, especially in people with extraesophageal complaints. We should be playing a major role in doing stuff about it. But what do we dilate nowadays? Well, we dilate virtually anything, mostly peptic strictures, radiation-induced stuff, neopharynxes, cricopharyngitis. Then we keep talking about webs and rings, particularly the small ones we don't even know are there. Nasopharynx we'll talk about, and then some people like to do this in the airway. We stopped doing that. People tolerate it okay, but we have such good anesthesia. We got such quick turnover. We do most of those now in the OR. So a couple of videos, kind of the routine stuff. People actually do a great job at tolerating this. Not everyone, but we go ahead and pass a guide wire through the biopsy port of the T&E scope. Then you have to withdraw the scope and go back in with the balloon, obviously over the guide wire. I go through the same nostril. It's already been numbed up. Our nurse numbs it up for us. We will sometimes have people swallow viscous lidocaine. A lot of times people do fine without, particularly if it's a neopharyngeal stricture, because it's so numb there already. And you do all of this under direct vision. It's important. You don't want to perforate. You want to watch. You want to feel. You can suction any blood or backed up saliva there. All done once again under the guide, over the guide wire. There it is. Looks sweet. People with cricopharyngeal dysfunction. Once again, we tried for a while to bend the balloons and do different things to try to avoid a step. And you can do that if you have large scopes, because you can put balloons through the channels, but the teeny scope, you can't put the balloons through the channel. I put that there like this. Our nurse accidentally checked the balloon. It inflated a little bit, then it's hard to crush it again. Never check these balloons. Never, ever check them. Put them down to the stricture and then inflate them. I left that there just as a reminder to explain that to people, because we screwed up. If you do the cricopharyngeus, once again, you keep this thing under direct view and no magic. Another one with the balloon, not inflated, thankfully. We've used this for, like I said, cricopharyngeus dysfunction, hypopharyngeal esophageal strictures, strictures after laryngectomy particularly, a handful of people with gastric pull-ups after having esophagectomies. You can easily dilate with this. And once again, remarkably well tolerated. I'd say 2/3 to 3/4 maximum can do this. But some people need, that's a 60 French balloon. Sorry, 20 French. No, 60 French, 20 millimeters, sorry. On a person with failure of relaxation of the cricopharyngeus. Put this there. You can dilate pretty much everything or anything. We published a series of patients with nasopharyngeal strictures after radiation therapy and after U-triple-Ps for sleep apnea. That developed nasopharyngeal strictures. You can't even put our flexible laryngoscope through that. So we're spraying lidocaine into this area, and then we're able to dilate this. And we had a great success rate. I think only one patient had to be dilated a second time. A lot simpler than rotating flaps into this area, and with a very, very high success rate. They are more sensitive in this area, and so we start with smaller balloons and then go up. You'll see here the difference. The original opening of the nasopharynx was about 2.5 to 3 millimeters, and then you'll see the difference here in a moment, but you'll notice it's wide open. There we go. Blow some air, just like here in the esophagus. A little bit of bleeding, but there you see right there. Nice and open. And only one patient had to be done a second time. So it's really, really encouraging. This is the technique. We made this some years ago for the Triologic has 4-minute technique things. Now I was invited to do this some years ago. So we'll go over this right now. It's nice to see Dr. Comer is watching right now. So we had them sitting this. We numb this with lidocaine and then cotton soaked in a 50-50 mixture of lidocaine and Afrin. Afrin probably being the most important part. Note I try to keep the scope as straight as possible. That way it doesn't fall out of the nose. That's how you can steer it easier. Patient puts their chin down. I ask them usually to swallow twice. The swallow will open the cricopharyngeus muscle. And then the rookie mistake is to sit there and take your time, but you really got to move fast through there. And they don't notice it much after that. Dr. Comer is not smiling exactly right now, but he looks like he's doing okay. So I like to look, the scope, the endoscope centers itself on the way out. So I tend to do most of my looking on the way in. You notice I start with a fishing pole, but a lot of people prefer to hold it like a GI doctor. I don't care how you hold it, as long as you can steer it. You steer both with your backhand as well as the hand on the scope. It's a single wheel. This is air. You push down all the way, you shoot water through it, and then you have suction in the back. Once again, single wheel. That's the 1.8 millimeter biopsy forceps that go through the channel, same channel that takes your laser, that takes your guide wires, and so forth. We did not biopsy Dr. Comer, I promise. Retroflexion, you rotate the scope 180 and totally reflux it, and you look back at the scope. And then I ask the patient to swallow. This is a poor man's manometry test. You count to yourself. It should be 13 seconds, count to 13 seconds or faster. You've probably got normal motility. There it was, right there. Some of Comer's saliva. Then suck the air out. You're going to feel bloated if you leave it in there. So sit there and suck the stuff out. Good swallow. He's swallowing water right now. Get a good look at the GE junction. Sometimes you have them swallow it. Sometimes you have them swallow water. And you slowly come out looking at all the mucosal surfaces. You want to get a 360-degree review of all the mucosa. We talked about, complications earlier. People are always worried about things happening, but complications are remarkably uncommon. And you'll get occasional, vasovagal episode, very rare, and occasional epistaxis, but it's usually fairly minor epistaxis that can be dealt with by just pressure on the nose. Sometimes epistaxis is a little bit worse. So that's, different fellows are known for different things. And I think Dr. Comer's most famous moment will be with the laryngology team rather than the rhinology team, I'm afraid. I should apologize, Brett, but I warned Brett that was coming up. COVID's taken away the Masters from us. If it does get played this fall, I don't think you're going to see azaleas like that around here. This is the 13th hole at Augusta National. Once again, this is my email. I love to talk about stuff. I'd love if folks are interested in the Dysphagia Surgical Society, if people are interested in discussing research projects, the Zenker study from Dr. Howell at Cincinnati, or anything like this, I'd really encourage you to email me. And interested in laryngology fellowships and how to begin that process, let me know. But it helped in a way. I'm thanks again for the opportunity to give some of these COVID lectures. Before we just, that's more golfing pictures. I figured you couldn't just get pretty golfing pictures. That was a few summers back in which one of our snakes was lowering the bird population. We got some. Go ahead, and we'll do a few more questions here for, we've got 15 minutes. Go ahead, Mike.
So you talked a little bit already about anesthesia and in-office procedures. We had a couple of questions about essentially.
No, louder.
A couple of questions essentially about what we're using to perform our dilations, whether that be balloons, dilators, and then how we determine what size we're going to go to.
Yeah, those are all good questions. Anesthesia is like, just we said, it's a spray. The nurse sprays the nostril, 50-50 mixture of lidocaine and Afrin. Wait a couple of minutes, inserts cotton, pledge it in there. I just rolled up cotton, throw in there. We usually leave that 8 to 10 minutes, and then go ahead and pass the scope for routine T&E. We will often give them a spray of acetylcholine or let them swallow viscous lidocaine if a stricture or a dilation is going to be performed. And usually not much more than that is needed. If it's done in the operating room, certainly we can sedate people. We tend to like balloons. If we're doing the super stretches, I've mentioned a lot of times 80, 90 French, there are a variety of ways of doing it. If a patient is awake, then you have to use 2 balloons. It's a little bit of a dance because you're going to have 2 balloons in place. Then that means 2 inflation guns being used by 2 different people. And as you inflate one balloon, the other balloon can be forced down in the esophagus or forced up, pushing the arytenoid over on the larynx. So it takes a little bit of coordination to do that well. If I'm doing the vast majority of my over 60 French dilation done in the operating room, I found it super simple to suspend a patient using a laryngoscope, place it in the post-cricoid region, lift up the esophagus the best one can. There are obviously some chemotherapy radiation patients, you can't expose anything back there. You go in, pass the guide wire if you need to, but if you can lift the larynx under direct vision, we will then put a 60 French balloon, that's the 1820 balloon, inflate it. If there's no bleeding of any significance, we'll then slide bougies alongside it through the laryngoscope. And so you can put, depending on which size Dido you have, you can put a 30 to a 34 or 36 bougie next to your 60 French balloon. And then still under direct vision, you inflate it up to maximal, then your 20 French. That's how you get to 70, 80, 90 French. Larger than that, we take the Dido out or work around outside it. But the use of a number 3 Miller blade is really good because you can actually raise the larynx with that. And then you already have your balloon down there. You can then put larger bougies next to it. We found it's a lot cheaper to use the bougie along with the balloon rather than using 2 balloons. We've had issues with reimbursement if we've used 2 balloons simultaneously on the same patient.
And then another question about Schatzky rings. Are we doing these in office or in the OR? And then advice regarding in-clinic T&Es with dilations in a non-academic setting without an extra pair of hands present.
Yeah, that last one is the tough one. Is that we're blessed with in a way excessive manpower, and so when we do these dilations, we have one person on the scope, another person on the balloon, and then a third person on the gun. It certainly would be, actually, you do a couple of these, I think I would have very little trouble holding the T&E scope and a balloon in my opposite hand. But it certainly wouldn't be optimal. And I think I'd have a little difficulty that I'm trying to hold the balloon in the right place, work the suction, and talk to the patient. So there'd be some degree of difficulty with doing that. So in general, it's a 3-person operation, which it would be more difficult, certainly in the private practice setting. Regarding the first question about Schatzky's rings, we have done those sometimes, but in general, we will let our GI colleagues take care of the Schatzky's rings in general. Sometimes when we've had radiation and chemotherapy patients with a pretty tight stricture in the hypopharynx or upper esophagus, we've actually suspended them, dilated that area, and then had our GI colleagues put their therapeutic scope down through there. The last one we did, we put a therapeutic scope down there. And what's nice about those is you can then put the balloon right through their working channels, and you don't need guide wires. And then we were able to blow up the Schatzky's ring. So it's kind of up to you, your level of comfort, and the ease of getting GI to work with you. If you have GI doctors that are in there, can get in your OR easily, then it doesn't hurt to have them involved. When we have achalasia patients involved, even if they have upper esophageal pathology, we've always referred those to our GI colleagues to use the larger balloons and their standard protocol for achalasia dilation.
That's it.
Well, once again, thanks so much for the opportunity. Strange way to meet some of you, but I wish you all well and hope you all stay well. And I wish during this time with you and your families, and I hope I want to give a particular thanks to Dr. Comer setting this up down here for us in the SEC. Always good, SEC strong and all that. It just means more down here. And can't wait for football season, I hope. But thanks so much, folks, and enjoy the rest of your day.